Okay, I'm going to get a head start. So welcome back, everyone. I have the absolute pleasure of introducing our keynote speaker for our 2024 symposium. Last year, we had Dr. Pauline Mackey come be our keynote speaker, but we are very lucky to have Dr. Lisa Larkin. Dr. Lisa Larkin is a board-certified internist and midlife women's health expert who has practiced in both academia and private practice since 1991 in Cincinnati, Ohio. She did her medical training at both Yale University and University of Chicago. Dr. Larkin's professional mission is to raise the standard of care for women across the lifespan. And I can attest to this. She's a trailblazer and innovator in our field and have looked up to her since the first time we met back in 2017. She is the founder and CEO of Miss Medicine, a national healthcare organization she founded to address the gaps in midlife women care, through innovation in clinical care delivery and through women's health clinician education. Today, Miss Medicine is a clinical network of female-focused concierge providers and physicians who are practicing in 10 states across the nation. Miss Medicine also supports a virtual education platform called Provider Hers that offers weekly women's health education to clinicians across the U.S. I personally attend these monthly or Monday night discussions regularly. So please let me know if you have any questions and if you would like to be a part of this group. It is continuously expanding. She is also considered a national expert in menopause medicine or management, sexual medicine, breast cancer risk assessment, prevention, and genetics. Dr. Larkin is a well-known educator and lectures frequently at physician CME programs and consumer education events on women's health topics. She actually has to fly out tonight to present at ACOG at 6:30 a.m. in the morning. I must add that she's basically a medical celebrity and has been in the news almost every week since the beginning of this year. Dr. Larkin has been on the board of trustees of the Menopause Society since 2018, serving as treasurer, then scientific program chair of the 2023 annual meeting, and now as president of the Menopause Society. Dr. Larkin formerly served as associate professor and division director of midlife women's health and primary care at the University of Cincinnati College of Medicine and is a director of the University of Cincinnati Women's Health Center. She is a fellow of the American College of Physicians, a Menopause Society certified practitioner, a fellow and a past member of ISHWISH, the International Society for the Study of Women's Sexual Health. Her bio kept on going, but I had to cut it short. So you know why we chose her as this year's symposium. Without any further delay, everyone, please welcome Dr. Lisa Larkin.
Okay, well, thank you very much. That was way too long, but I'm very grateful to be here today. This is a topic that is near and dear to my heart, and I'm really happy to be here. So these are my disclosures, and you can see I do a lot of consulting in the menopause space. I have no disclosures in the breast or the genetic space, nothing to do with this talk at all. These are our objectives. Now, what you don't know about me is I always have too many slides and I talk fast. And so in the interest of time, I won't read all of these, but they're in your syllabus. So breast cancer. I think all of us as females worry about breast cancer. I'm actually a breast cancer survivor now, just hit 10 years. And our patients worry about breast cancer. And I think our patients actually hear this statistic all the time, this 1 in 8, and this 12% lifetime risk of developing breast cancer. And I think it's important for our patients to know that. They worry about that. But what's really important is that that doesn't mean that's the risk of the individual patient sitting in front of you. And what I hope to convey to you today is that we need to think about breast cancer risk individually in the same way we think of cardiovascular risk. So I'm a clinician. I still see a lot of patients. I do both primary care and consultative women's health. And I like to use patient cases as an example. So I have 2 cases to talk to you about today. These are very typical patients for me. This is Liz, and I bet these are typical patients for you. So she's worried about breast cancer. She's 52. She doesn't get much medical care. This is the age when I would argue that women fall through the cracks. They're done with childbearing. They don't really have significant health issues. They're not seeing their OBGYN very much anymore. They're not really seeing their internist yet, except maybe for a sinus infection. And I would argue, and this is why I'm in the space I am, that this is the most important time where we can actually impact impact how a woman is going to age if we actually had more opportunities to care for her in a really evidence-based way during this midlife. So this is a typical patient, right? She doesn't come in very often. She's getting her mammogram. She's postmenopausal for 2 years. She has mild hot flashes. She hears negative things about hormones, and so she never even talked to anyone about that. On her mammogram, she knows she has extremely dense breasts, and she doesn't take any medications. And yes, she has a mother who died of ovarian cancer at age 80. Catherine, also worried about breast cancer. She's 56. She has high cholesterol and hypertension that's well controlled. She's also postmenopausal for 2 years with mild hot flashes. She also had a negative mammogram 6 months ago. She also has extremely dense breasts. She has no family history of breast cancer or ovarian cancer or any cancer in 3 generations. And so these 2 women are both worried about breast cancer, but their risk of developing breast cancer is not the same. And yet we continue to treat women the same, right? And that's really the point of this discussion today, is really hopefully to get you to start thinking about individualized and precision care for women. And why do they have different risks? Because there's lots of things that influence risk for developing breast cancer. So some related to genetics, and then others related to what we call modifiable and non-modifiable risk factors. And you can see it's just a smattering of women that I put here, some who carry hereditary cancer mutations, a woman who had ALH on a previous biopsy. And then you see that risk can be all over the map, but the risk is not the same. And I want you to step back again and think about how we approach cardiovascular disease and realize that we're not approaching breast cancer the same way. Everyone knows about what risk factors are for heart disease. We actually do a pretty good job of educating consumers about if they have risks for heart disease, how to modify those risks. We do a good job in clinical medicine of estimating the risk. ASCVD risk score, it's common. We use it. We talk about their risk of developing heart disease, and we really work to reduce patients' risk. We educate them about all the things that they need to do. The way that we're approaching breast cancer is not that. We're telling women just to get their annual mammogram. That's about all primary care doctors are doing still right now, right? Get your annual mammogram. That's what our metrics are that we're scored on, right? But that really isn't addressing individual risk. It's doing nothing for prevention. And I would say in the cardiovascular space, that would be like just telling our patients to get an annual stress test and not addressing risk, right? It's when women go to get their mammogram, they're just waiting to get called for that abnormal mammogram that says, you need a biopsy, we think you have breast cancer. And this, I think, is a great slide from my dear friend and colleague, Dawn Musalem, who's at the Mayo in Jacksonville. And really, it's, we continue to just focus on breast health for waiting until someone has largely a breast cancer diagnosis without addressing individual risk and then working towards prevention in the same way we do for cardiovascular disease. So for those of us who see women, which I think we all do, right? We know that midlife is the time when women are worried about getting breast cancer, and you can see why. If you look at the incidence of breast cancer, it really is the peak between 45 and 65. And again, this is when women have the least points of contact with healthcare. But again, the incidence of breast cancer does go up over the course of the entire lifespan. And what about mammography? So this is a really big topic right now. What we're doing with mammography is we're just using age as our criteria for screening. We're doing nothing with taking into account individual risk. This is not precision medicine right now. We're just saying it's an age-based thing. It's not based on actually figuring out risk or ethnicity. And what you may have heard, and I just updated these slides, is just last week, the U.S. Preventative Services Task Force came out again with the final recommendation. And finally, at least, the U.S. Preventative Services Task Force has come into line with the age at which we start mammograms being 40, at age 40, which I think is good news for women. But still, there's just differences among all of the professional organizations. And I would tell you, you have to ask, how can we all be looking at the same data from mammography to come up with guidelines? And why do professional organizations all still have different guidelines when there's millions and millions of data points on how good mammography is, right? I would argue it's because we're just trying to homogenize all women, right? So the data really doesn't show us exactly what we need to know. And so we end up with these disparate guidelines. You can see that the interval is the big thing. The U.S. Preventative Services Task Force is still recommending every 2 years, whereas the other organizations, it's annually. And then there's really debate about when to stop. I would tell you later in the talk, we're going to talk about the differences in these guidelines as it relates to what we do with women with elevated breast density, which also makes these guidelines now really confusing again. And what about mammography? Well, it's not a perfect test. We all know this. It is the only test we're using right now that's demonstrated to decrease mortality, but it's really limited. 20% interval cancer detection rate. That means that these women who are up to date on their mammogram may have a cancer detected in between their mammograms. And why is that? Because the false negative rate is high. It's 4 to 24%, and it really relates to breast density, which is why you're now hearing a lot of buzz that we're going to talk about and recommendations for women who have dense breasts to get enhanced screening. The other thing is the positive predictive value of mammography is low. That means that false positives are common. So we all know that women are getting called back. We all see this, right? The chance of a false positive with one mammogram is 7 to 12%. 50% of women will have at least one false positive recall. 17% will get that false positive short interval follow-up, and 11% will have a false positive biopsy recommendation. So again, mammography is what we're using, but it is certainly not a perfect test. And I love to say it this way, which is that it's great when we see something on mammography, right? It's the iceberg that we can actually see. But the problem with mammography is we're not seeing all the things that we need to see, worse in women with dense breasts. And this is why we have interval cancers detected. And what we know is that the mean time for a breast cancer to grow from 1 to 2 centimeters is 1.7 years. So when you have a woman who has a breast cancer that's above 2 centimeters, like I did 6 months after having a negative mammogram, you know that that breast cancer was there on at least 1 and maybe 2 prior mammograms. We just couldn't see it. What we know is that, again, we said this 20 to 33% of cancers are detected between screening studies, either symptomatically or by another modality. And what about racial disparities? We know that this exists. We know that African American women have a higher chance of having breast cancer diagnosed at an advanced stage. 53% of African American women have tumors at diagnosis over 2 centimeters compared to 43% of white women. And we know we're going to talk about that there's also the difference in triple negative, the prevalence of triple negative. So you can see here, African Americans, 24% of the time have triple negative disease. And we know that that's the bad actor compared to 12% of white women. We don't exactly understand these racial disparities and why right now, but they clearly exist. And mammography, I just told you it's not a perfect test. It's certainly what we need to be doing now, because why? We need to detect cancer early, because cancer size at diagnosis directly correlates with survival. And so we want to be really thinking proactively, who are our high-risk patients, and really, again, talking about who meets criteria for enhanced screening. And what about racial disparity in breast cancer mortality? Well, the good news is if you look between 1999, and this goes only up to 2014, that the trend is down. We do see decreasing mortality, but if you look at the top with African American, we see across the board, their mortality has not come down. It's higher consistently above all other races and ethnicities. And again, this is really something that requires more investigation, and we need to do better. This just recently came out, and I think that this is really important to talk about, which is we're now seeing increased incidence in really our much younger patients with breast cancer. So this is significant and new, and anyone who wants to attribute all of the breast cancer to the use of postmenopausal hormone therapy really should take a look at this slide, because it's clearly not the only thing that's going on. If you look starting in 2016, which was long after the WHI and the decline in use of menopausal hormone therapy, and again, 20 to 49-year-old women are not those who are using postmenopausal hormone therapy anyway, that there's that very significant, dramatic, going from an annual percentage change of 0.24 up to 3.76 in terms of the incidence of breast cancer in our younger patients. And again, we really don't understand this, but I'm sure you can understand that with this, right, mammography starting at age 40 in women who are still of reproductive age, they typically have more increased breast density. So mammography isn't as great a test, and they actually were continuing to see earlier and earlier breast cancer. So my argument today with this talk is that we want to have precision medicine, and what we want to try to figure out is what is the individual patient's risk of breast cancer sitting in front of you? How can we do a better job personalizing risk and talking about more personalized risk reducing strategies. And I would tell you that, again, mammography is important and early detection is important, but wouldn't it be better, and shouldn't we really be trying to do what we do with cardiovascular disease, which is really preventing breast cancer, right? And I would say we really have to identify those women at high risk if we're going to prevent breast cancer. And what do we know? We're failing to identify the majority of women who carry hereditary cancer mutations that put them at significant risk. And we're also failing to identify those women who don't carry a mutation but are at high risk for non-genetic reasons. And this is the point of this talk. I'm hoping by the end of this, you have a sense of how you might approach assessing risk in your practice. So I've been kind of giving this talk or talking about risk assessment and doing this work really for the last 7-8 years now. It's great to see, menopause is having a moment because of all of the, social media celebrities that are now becoming menopausal and have really started to drive change. But I think this was really very significant because this was the first time with Olivia Munn's diagnosis that I had anyone ever seen on any of the major news outlets talking about breast cancer risk assessment. I've been kind of shouting it for the trees from the trees for years, but I think that this may be, just like with menopause, the beginning of kind of a sea change, and where we're really going to be having women who start to ask questions. What's my individual risk? So how do we assess risk? Well, there's non-modifiable risk factors, and these are the genetics. Again, remember, your patients still believe that if they don't have a family history of breast cancer, that their risk is relatively low. Remember, you've got to educate them that that's not the case. 75% of breast cancers occur in women who do not carry any genetic reason to have their breast cancer. 5 to 10% have BRCA mutations. 10 to 15% carry other mutations or occur in family clusters. But again, it's more common than not for a woman to develop breast cancer that does not have a family history. We also know reproductive factors, right? So early puberty, specifically women who are under age 12, and we're seeing that more and more now. For every 1 year delay in menarche, risk goes down. Late menopause over age 55, not having children has a relative risk of 1.2 to 1.7. And then age at first live birth. So having your first child under age 30 is protective. The older you are when you have your first birth increases your risk, and there's no change in risk with infertility. And I just had another case this week, and I use this slide to make the point, I hope, to every single one of you in the room, that if you have a patient sitting in front of you who's had a prior biopsy and they don't remember what the pathology is, I really encourage you to go back and look. I say I have one case a year. I've already had 2 cases this year where I've gone back and looked at the pathology. I had one this week where the patient had ADH 10 years ago. The patient this week for me was a woman who she's 56 now. At 46, she had a breast reduction, completely just a breast reduction on both sides, and the path came back with an area of ADH in one of her breasts. She saw the plastic surgeon, she saw a breast surgeon in follow-up to that. No one talked to her about really what her lifetime risk was with that ADH diagnosis, and no one had even been doing enhanced screening, never mind talking to her about chemo prevention. So again, please go back and look at the pathology if you can find it, because ADH confers a lifetime risk of 35%. LCIS, again, relative risk of 7 to 11. What I want you to see on the right-hand side is the one thing there, if you can look at, and it's hard to see really, but the bottom 2 lines are no prior biopsy compared to a non-proliferative, so a biopsy that really is considered insignificant. You can see that for some reason, women who undergo biopsies, even if they're benign, still are at increased risk. And you may know this is one of the questions when we do the Gale model is, again, any prior biopsy confers increased risk, but we really want to find those ones that are LCIS and ADH and ALH. Okay, breast density. The good news is I predict, how many of you have had patients coming in asking you about breast density now and what to do with it? Okay, few of you. So breast density is really all the buzz now, and I'll give you some slides as to why, but 50% of the population now, 4 categories of breast density, A, B, C, D, replaced by fat, scattered fibroglandular density, heterogeneously dense, and extremely dense. Women are getting density information already in their mammogram reports. I can tell you when I do community-based lectures over the years, women when I would ask them if anyone knew their breast density, no one would raise their hand. Now it's becoming more and more common, but still women don't understand. And I will tell you, doctors don't know what to do with the information exactly yet too. When women say, yeah, I've been told I have increased breast density, but it's kind of like saying, you have blue eyes. Like, what do you do with that information exactly? Women don't really have a great understanding of how that confers increased risk. So certainly we talked about increased breast density decreases the sensitivity of mammography, but it also confers increased risk. So if you look here, if we use fatty breasts as a relative risk of 1, you can see that the scoring, so it depends on the percent of glandular tissue. And I would comment that density is not something that you as a clinician can tell based on exam. It's not something patients can tell. It really is, they need to have their first mammogram to get an accurate sense of their breast density. And depending on their percent of it's glandular tissue compared to fat, and you can see the one all the way at the right. So that is almost entirely glandular tissue. We know that because it's white. You don't see a lot of black. Fat shows up as black on mammograms, and it confers a relative risk of 5.3. So again, breast density is really a significant risk factor, obviously not modifiable. And what about modifiable risk factors? So I'm glad I followed some of the talks today, because actually this is good to follow up on this. So lifestyle matters. As I mentioned, we do a great job talking to patients about cardiovascular risk and lifestyle. We don't do it at all, or very little still. It's really not. I would really like to see a national messaging campaign, because I really believe that midlife women would be more motivated to do the lifestyle changes that they need to do if they really understood their risk for breast cancer, because they just still at midlife put heart disease like 25 years down the road, and they're not very motivated. So what do we know about diet? Well, there's lots of epidemiologic studies. The bottom line is more cruciferous vegetables, less animal protein, moving more towards a Mediterranean diet. The data is overwhelmingly clear that it decreases breast cancer incidence and decreases recurrence in women who have breast cancer. And the data is compelling. And what I point out here is that really, if we look at risk factors for cardiovascular disease and we look at risk factors for breast cancer, you can see that there's huge overlap. And again, I think this is an opportunity to talk to our patients again and remind them that what they're doing that's good to reduce their risk of diabetes and heart disease also is decreasing their risk of breast cancer. This big trial from the Women's Health Initiative, so this was the diet arm of the WHI, so this was almost 50,000 people. This was really a simple arm. This was women were either eat regularly or they were told to just try to have a low-fat diet. It wasn't more aggressive than that. And you can see that breast cancer mortality was reduced 15% just by making that small change, right? 15% reduction in all-cause mortality with a simple dietary change. And what about exercise? Again, the data is overwhelmingly clear. Again, exercise is so important for so many things, but it also decreases breast cancer incidence and it decreases breast cancer recurrence in breast cancer survivors. So as part of survivorship, really, we should be talking to our patients, but also, again, for prevention strategies. And what about weight? So again, this is a huge big deal. We heard some about that now, but in terms of incidence of developing breast cancer, it's really, really important that we talk to our patients about weight. So obviously you can see a meta-analysis with weight reduction 0.82 in the WHI in women who lost weight. It was 0.88 in the Nurses Health Study, 0.77. And the data is very clear in women who undergo bariatric surgery that they have a reduced risk of developing breast cancer. What about alcohol? This is my favorite thing to talk about, or one of my favorite things to talk about, because again, women do not understand that alcohol is associated with breast cancer risk. I don't know about you, but in my practice, it's often my midlife women who start to drink more, right? Their kids are away at school, they're empty nesters, their career is often hitting their peak, they're socializing more, they have more business dinners, and they're drinking more. And again, this is really a significant thing. I would tell you, there's really, those of us that look at this data would tell you there's really no safe alcohol. You know, we used to say that it was 1 drink a day for heart protection. I can tell you that that's not really based in good science. You really need very little red wine, about ½ glass a day, so about 3 drinks a week to get the heart protection. And so really when I talk talk to patients, again, I think telling them they can't drink at all is often hard, but I try to get them to be very mindful and try to get to 3 drinks a week, but it would be better if they completely abstained. What we know is, again, in the US, this is a big deal. Women are drinking, and we think now epidemiologically that it accounts for about 12% of breast cancer. It increases the risk of developing breast cancer in pre- and postmenopausal women. And again, we think about alcohol use all across the lifespan. So this is really important to be talking to your younger patients, college-age patients as well. And so again, discuss alcohol. And then what about soy? So this comes up all the time in the survivorship arena, but I can tell you that there's pretty clear data, and I love to talk about this, that moderate consumption of soy is safe for both survivors, and we really do not believe that it increases risk. We really encourage a diet that's high in soy. We know in the Asian population, soy consumption, really is associated with lower risk. We think that that's earlier consumption of soy. When Asians come to the US and are on an American diet, they very quickly get back up to American rates of breast cancer. And what about prevention? So again, I talked earlier use in the Asian population. This data comes from a reduction in breast cancer incidence. And again, use post-diagnosis, reduced mortality and decreased recurrence rate. And again, it didn't matter what they were on for anti-hormone therapy. So lifestyle is the silver bullet. We really need to talk to our patients about this. I love this slide from the World Cancer Research Fund on the right. I mean, if you think about this, right, we know the number 250,000 cases of breast cancer estimating in the United States per year. The data really suggests if we could get our patients having a healthy diet, exercising, maintaining an ideal body weight, not smoking, and really minimizing alcohol, we could prevent 33% of breast cancers and even more colorectal cancers than that. So it's really important. And what about risk factors? And I just want to point out here, and again, we're going to talk a little bit and how I approach patients when it comes to menopausal hormone therapy and how I talk to them about breast cancer risk. I want you to see from the WHI on the upper right, with hormone therapy, and that's the estrogen plus progestin arm, the relative risk was 1.2. But you can see my white arrows there that it just correlates. If we look at obesity or a high-fat diet or alcohol consumption, again, when you have a patient that comes in and says, I will never go on hormone therapy because it causes breast cancer, you really want to talk to them about the other things that are associated with breast cancer, particularly being overweight or obese, a high-fat diet, or drinking alcohol, because those are modifiable risk factors. And again, you want to make sure that, again, they're not over-dramatizing hormone therapy as the big, bad, evil thing when they're have all these other modifiable risk factors that they can adjust. Okay, so switching gears. How do I think about breast cancer risk assessment in my practice? So I think of 4 buckets. And we're really going to focus on the 2. So if you can think about anything, I want you to think about how you would do better. We all are not doing well at identifying our hereditary mutation carriers, and then those individuals who are really at the highest risk, which is a lifetime risk of greater than 20%. So how do I go about doing this in my clinical practice? Well, I want to set the stage. That some important statistics. So 1 in 500 women in the United States carries a genetic mutation, and that's much higher, 1 in 40 in Ashkenazi Jewish individuals. We need to be thinking about this in practice. And these NCCN guidelines are here. And again, this is in the document that I sent out. So you have these. Again, what you want to think about when you have the patient in front of you. And again, the problem with healthcare delivery, right, is visits are short. So we don't often or all the time do a great job of updating family history or talking about this again. But what you want to look for is young incidence of breast or ovarian cancer, pancreatic cancer, Ashkenazi Jewish descent, male breast cancer. Look for flavors of cancer. And then again, if you are not comfortable really doing an assessment in practice or don't have the resources, looking for a way to screen your patients to refer them to a genetic counselor. I do genetic testing in my office, which I can talk about. But again, you really want to think about this. Because what we know, and this is a really well done study, 1 in 4 women sitting in front of us meets criteria based on that. I actually did several breast cancer, this is 5 years ago now, breast cancer consumer events in my community in Cincinnati. And I got exactly the same data, which is about 25% of the women who came to these events had elevated breast cancer risk above 20% when I did their Tyrer-Cuzick, and 1 in 4 of them met criteria for genetic testing, and none of them had ever been assessed for that before. And so this was a study looking at about 4,000 patients who were screened with a family history questionnaire. Of those, almost 1,000 or 24% met those criteria for genetic testing. 813 were offered testing, but only 165 completed testing, so 4%. And in that 165, 9 out of 165, or 5.5%, had a mutation. Can you imagine how many we just missed? Because if 903 met criteria, we only tested 165, we missed a huge number of women, and this is in a setting where we were doing screening. So we have to get better at this. I can tell you that there's barriers, and what we know is that, again, I use this paper screener in my office. We've played around with some technology, sending patients through text messages, screeners that they can complete before their visit. But that's been cumbersome for us to operationalize. So we went back to this paper screener that I do at every time a patient comes in for their physical or their well woman exam. But what we know is that the majority of clinicians just aren't able to do this, or they don't have the infrastructure or the staff. And so it's really just time consuming and difficult to operationalize. And so this is part of the barrier to missing these people who carry, who meet criteria and who should get genetic testing. And what we know is that it extends beyond breast cancer, right? If you look, it's ovarian, breast, colorectal, endometrial, pancreatic, and prostate. And look at the prevalence. I mean, if you look, 19% of people who have pancreatic cancer actually carry a mutation. It's 18 to 24% of women with ovarian cancer carry a mutation. And just depending on the tumor type, you can see the prevalence there for breast cancer. And so again, if we think about this and we know the prevalence of these cancers in the United States, you can see that if we did a better job identifying these mutation carriers, we could prevent 60,000 cases of cancer in the United States per year. And that's preventing cancer. That's not detecting it early. And unfortunately, what the data really shows is that we are only right now identifying about 10% of women who carry a mutation. We've got to do better. And we need to think about how we can use technology to improve that. And so when we go back to our patient and think about Liz, she had the mother who had ovarian cancer at age 80. She meets criteria for testing. And I can tell you, she's the patient who gets missed, right? Her mother was older at death. Family history is one of those things that doesn't get re-updated. And she was never offered testing. But lo and behold, when she does get testing, she's BRCA1. And so this is Liz. So she has a lifetime estimated risk of 72% for breast cancer, 44% risk of ovarian cancer. This is probably the most impactful thing you can ever do, is make this diagnosis for this patient. Why? Because you can prevent her breast cancer, right? You can at least do enhanced screening. You could talk about all of the important things for risk reducing measures, certainly lifestyle, but she's really someone you would talk about chemo prevention for. Risk reducing surgeries, she clearly should have discussions about removing her ovaries and or consideration of prophylactic mastectomies. And then the other thing, this is about identifying mutation carriers in her siblings and her children. And so this is a really big deal, and we need to do better at this. But let's switch gears and go back to Catherine. So she has no family history in 3 generations, so she doesn't meet NCCN guidelines for testing. What I would tell you is I'm a huge advocate of this. There's a whole group of us in the genetic space that we really are very passionate about this, is that you can make a case for population genetic testing now. So the cost of genetic testing and doing these panels has come down dramatically. I was diagnosed with breast cancer at 49, 10 years ago. And so when I had genetic testing, I paid $4,000 out of pocket for it. Now to do hereditary cancer, an 84 gene panel, which I do in my office, it's $250 cash. And you only have to do it one time. You can make an argument, I believe, that because we're missing so many women and because collecting family history has really been shown to be ineffective, that we should start looking at what the cost-benefit analysis is of population genetic testing. This is the other reason that I'm really for this too. So this is thinking about all of your breast cancer patients, right? So I think there is data to support testing all breast cancer patients, regardless of the age that they are when they have breast cancer. Because what you want to see here, and you don't have to look at all of the mutations, but look at generally the blue and the yellow. They're relatively the same number of patients with mutations. And what this was is 1,959 breast cancer patients. All of them had panel testing for 80 genes. They went back and did family history. Half of them met criteria for testing, half didn't. And what you look is the number of mutations identified was exactly the same, whether or not they met criteria or didn't. The prevalence of a pathogenic mutation was 8.2 to 9.6, regardless if they met family history, right? So family history clearly is not perfect. We should be thinking about, I think, population testing, but at least testing all of our breast cancer patients. Okay, so moving to risk assessment. How do I do this? So there's a lot of models out there. I can tell you the two that I use. So I use the Gale model and I use the Tyrer-Cuzick version 8, and they're very different, and they give different results. And I'm going to show you with these patient examples how we calculate this. The reason I like the Tyrer-Cuzick the best is because it takes into consideration all of the things that you see at the left. So it takes reproductive factors into consideration. It takes weight, biometrics, BMI. It incorporates breast density, it incorporates prior biopsy information, and it takes a 3-generation family history. And so again, this will often be much higher than doing a Gale model, but I'm going to show you how I use this with patients. So the Gale model, if you only do one thing, because you don't have time to do the Tyrer-Cuzick, but I would argue that if you get used to doing the Tyrer-Cuzick, you can do it really fast and it's really easy to do. But at the very least, the Gale model is 5 questions. It's easy to do. It takes 1 minute, and it really estimates lifetime risk of breast cancer in women over the age of 35. Now, the problem with it, in my opinion, it does not take into consideration biometrics at all. It doesn't take into consideration multi-generational family history. It only takes 1 generation of family history. But most importantly, it doesn't take into consideration breast density. How does that compare to the Tyrer-Cuzick? So this I will tell you on my physicals, I pull this up on the screen with patients and I do it with them. And the reason I do that is I show them how I'm entering the data. And then when I get the results, I play around with the data. I show them what a change in breast density does. I show them what a change in body weight does. I show them what family history does and does not do to their calculated risk. And it's really impactful, I think, really with the weight. The one thing that the Tyrer-Cuzick does not take into consideration yet, but I understand it's something they're working to get the data to actually incorporate, is alcohol consumption. But again, these are the two that I do with patients. And if we go back to Catherine and we talk about doing this with her, you can see I put the Gale model results up top and the Tyrer-Cuzick down below, and you can see they give different results. But what both of them are doing is comparing what you're calculating the patient's risk is calculated to be compared to the population. So you can see that the population risk for this patient at 56 years old is 11%. And you look at how that compares to her lifetime risk of 18%, which is calculated by the Gale model, but 23.4% when you use the Tyrer-Cuzick model. So this is a patient who hits that 20% lifetime risk calculation and meets criteria for enhanced screening. So what are the current guidelines? So we're going to talk about how these are evolving right now because it's kind of a hot mess. But the guidelines really to think about are patients who have that lifetime breast cancer risk of above 20%. And so I do this all the time in practice. So when I get a patient who has a 20%, I'm literally, when I'm ordering their breast MRI, I'm writing in their comments. Extremely dense breasts, calculated Tyrer-Cuzick version 8, 26% meets criteria so that I can get insurance coverage. And when I do that, I actually haven't had problems with that. The other criteria is, again, these patients with ADH or LCIS. I told you about the patient I just looked at her pathology and identified ADH on that. And again, she hadn't been getting enhanced screening. Anyone with a BRCA mutation, a first-degree relative who has a BRCA mutation, but the patient hasn't had testing. And the other category that we continue to miss is patients who've had chest irradiation due to Hodgkin's in their 20s. I have seen this more times than I wish I have, which is patients when they have Hodgkin's at age 18 or 20, they get their mantle radiation, they are cancer-free and they are living their life, and they are not thinking at age 35 and 40 about breast cancer, and they need to be because they have early and very aggressive breast cancer. But what about these guidelines? So in 2019, they were really updated to talk about breast cancer survivors, and I can see this is being missed too. So again, we want to think, right, if you have a patient who has a lumpectomy, should we just be doing mammograms on that patient? What if they still have dense breasts? And the criteria were updated. Certainly anyone who had breast cancer, who's a mutation carrier, should be getting an annual MRI. The American College of Radiology says anyone with dense breasts and a history of breast cancer should be getting annual MRI. Anyone diagnosed with breast cancer before age 50, and if they have lobular histology. Okay, and I don't have time to talk a lot about chemo prevention, but again, this is something that patients have never heard of. I lecture in the community and I say, how many of you know that there's medications out there to reduce your risk of developing breast cancer? Nobody. I mean, I never have a patient raise their hand. And we know that this is another area where internists are not doing what they need to do. It's like a hot potato. Who owns doing chemo prevention for breast cancer? Who owns it? Who wants to manage this? OBGYNs? I'm not sure they want to manage it, right? Primary care, they're not doing risk assessment. Do they really want to manage it? And what I see is patients don't know their risks, so they're not actually ending up in high-risk screening clinics until they have cancer or a family member has cancer, and then they end up. And so again, we're missing all of these patients. And if I can just implore, it's not hard to do. You guys can all do chemo prevention if you spend a little time just learning about it. And the guidelines really are, NCCN says it can be anyone with a Gale above 1.7. I don't use that. Most people do not. Typically, it's if they have a 5-year risk by Gale of greater than 3% or a Tyrer-Cuzick 10-year risk greater than 5. And again, those are numbers, right? So Gale risk greater than 3%, Tyrer-Cuzick 10-year greater than 5. And so if we go back to Catherine, so she's clearly high risk. She has that 10-year of 6.1. She has a lifetime risk of 23.4. So she is absolutely a candidate for both enhanced screening and for a discussion of chemo prevention. And this is a patient, again, is in that bucket of high risk that we're kind of missing. And so how do I approach Catherine? So I really focus on lifestyle for her and I talk to her about the chemo prevention and what we should be doing with enhanced screening. But I'm going to play a game with you now, and I'm going to mix up the data. So what if I change her and I say, okay, she doesn't have extremely dense breasts. Now she has heterogeneously dense breasts. So she has category C, not category D. How does that change her risk calculation? So now all of a sudden, instead of being a lifetime risk above 20, she's a lifetime risk of 17. So she falls into that intermediate risk category. Okay, now what do you do with her, right? Is 17% really very different than 20%? I sometimes have patients who have a 19.2% lifetime risk. Is that really different than 20? Like 20 is kind of arbitrary, right? But really, what do guidelines say and what do we do with this patient? Well, so as I mentioned, patients are now getting information about their breast density in their mammogram letters that they're getting. As of September of this year, it's now nationally mandated that women get something. This is a mammogram report that my patients are getting that says women with heterogeneously dense breasts, that's category C, or extremely dense breasts, category D, should discuss with their primary care provider whether supplemental breast cancer screening with MRI with and without contrast is indicated. Well, I can tell you, patients are going to their primary care doctors, and their primary care doctors do not know what to do with this information, and they don't want to deal with it because if they don't actually have and I'll show you why, calculated Tyrer-Cuzick risk, they're not getting the MRIs covered. And so then patients are often getting $4,000 bills for their breast MRI. And again, it's really kind of hot potato. Who wants to manage this? And this is now being sent to women in their letters. And what about the American College of Radiology guidelines? So these were updated in 2021, and this is where this really comes from, which is that they are saying average risk women with dense breasts, so it's C or D, should consider it. That's why this letter is there, right? The American College of Radiology is saying they should get contrast mammogram, breast MRI, breast ultrasound, or abbreviated breast MRI, and this is where that language comes from. But not everybody agrees. So the 2023 NCCN guidelines say, and I've highlighted it there at the bottom, that heterogeneously or extremely dense breasts on mammography, they can't decide if that's enough to recommend for or against MRI screening. And then this is our patient, right, in that intermediate risk between 15 and 20%. Again, can't really say that that's the group that we should be doing breast MRI. So NCCN and ACR, they disagree, which leaves patients and clinicians, if clinicians even are looking at this data, in a quandary. And then we have what the U.S. Preventative Services Task Force just came out this week, just adding to the confusion, right? So again, we now have guidelines that are all over the map. They say that, again, women with dense breasts, they can't tell you that we should be just doing breast MRI on these women. So now the American College of Radiology is sending out letters informing patients, and we have NCCN and the U.S. Preventative Services Task Force that disagrees with those recommendations. So what are we doing? Well, I want to tell you, in my practice, which may be different than yours, and in my community, our academic health center is now doing abbreviated breast MRIs, and one of our private imaging groups is now doing abbreviated breast MRIs. I was very concerned about ordering those until about a year ago, when the data really did start to come out from trials looking at these, that the sensitivity and specificity was almost as good as the full sequence breast MRI. So the difference between an abbreviated protocol and the full protocol is you still need gadolinium, but it's about 20 minutes versus a 60-minute scan. And in my community, they're doing it for $400 or $425. And so for patients where it also comes into play, and like, this is like how hard practicing medicine is, right? Like, not only do I have to talk to the patient about whether or not they should get the breast MRI, but I have to ask them about their insurance. Do you have a high deductible plan? Have you met your deductible this year? You know, and think about, can you afford doing a $400 abbreviated breast MRI? Like, there's all of these barriers, because patients who haven't met their deductible, even if they have insurance coverage and we do a full sequence MRI, they're going to pay $4,000 out of pocket. And so again, that if a patient gets a $4,000 bill one time for a breast MRI, they're very reluctant to do a breast MRI the next year. And I think we're kind of shooting ourselves in the foot. So there's times when I'm now recommending abbreviated breast MRI. And certainly in my patients who have that 19.1% calculated risk, I'm at least talking to them about it, because now the data looks good, that this is just as good as a full sequence breast MRI. And I'm sorry, did you miss that? Go back, you can take that. Okay, so what if she comes back with heterogeneously dense breasts and I do her tyrocusic and she comes back under 15%, right? Which I see all the time, right? I actually just did a tyrocusic on a patient with heterogeneously dense breasts, and her calculated risk, because she was thin and she had late puberty and a really early pregnancy and no family history, came in at 9%, like at low. So what if her risk doesn't come in at 17%, it comes in at 14%? Now what do we do with her? And I would tell you again that this is now, NCCN says we shouldn't be doing MRIs in this patient. But again, the American College of Radiology is telling us we should. So I think it's very confusing. Okay, switching gears. Don't miss the forest for the trees. And I talk about this all the time. Midlife women are worried about breast cancer. They need to also worry about cardiovascular risk. Cardiovascular risk increases dramatically at midlife. If you calculate her ASCVD risk score, her 10-year risk of heart disease is higher than her breast cancer risk. So don't miss that we have to be talking to her about lipids and blood pressure and exercise and all of the things that she needs to be doing for both cardiovascular risk reduction and breast cancer risk reduction. Okay, now I'm going to make her even more complicated. So what if she has terrible vasomotor symptoms? She's sitting in front of you saying, I am miserable. And you calculate her risk and it's 23%. And I just told you, she meets criteria for chemo prevention, but she's miserable. So is hormone therapy an option for her? I can tell you that, again, every internist in my community, I just had a patient come in for a consult who told me she saw her internist. She wasn't this patient, but someone with severe hot flashes. And her internist literally said to her, our practice is a hormone-free practice. We don't prescribe hormones. Menopause is natural. Okay, so that's the level of understanding of menopausal hormone therapy. But again, this is a little bit of a nuanced case. This is why I think menopausal medicine, I mean, we have to really be educated about this to do a good job doing shared decision-making with our patient. But this just came out too, right? So this just came out, actually not just recently. This is the guidelines from the U.S. Preventative Services Task Force about menopausal hormone therapy, which is very clear. Menopausal hormone therapy should not be used for the primary prevention for diseases. Now, cardiovascular disease, dementia, and I can tell you there's a lot of people in the menopause space, and many of them are very active on social media right now, who are out there really poo-pooing the U.S. Preventative Services Task Force guidelines. But I think you have to remember, and this is what many of my internist colleagues rely to, right? They say, look, even the U.S. Preventative Services Task Force says that hormones are bad. Well, again, this is primary prevention. That's not our patient who's having severe vasomotor symptoms. This is not the data from the U.S. Preventative Services Task Force. So let's talk about what the Menopause Society, formerly NAMS, actually says. Well, so in the most recent position statements, it says breast cancer. A preponderance of data does not show an additive effect of underlying breast cancer risk, age, family history of breast cancer, genetic risk of breast cancer, benign breast disease, personal breast cancer risk factors, and hormone therapy use on breast cancer incidence. The patient sitting in front of me where I have this conversation, I do their risk, right? I just did this in Catherine, it's 23%. And how do I talk to her about that? I say, look, you are high risk. The biggest risk of having breast cancer is being female and having breasts, right? I can never tell a woman sitting in front of me that she has zero risk of developing breast cancer. But the conversation here is, how do we talk to a patient about what her baseline individual risk is based on her genetics and her breast density? And then what impact does hormone therapy actually have on her risk? And how do we counsel her about that? Well, this is a very good paper that came out in 2023 that I really like this. Many of you, if you look at the lipid and statin data, it has this red light, green light, yellow light kind of format. So they used it for this. How do we think about which patients are the best candidates for menopausal hormone therapy versus not? So low risk patients, these are the patients who clearly get benefit. They have symptoms, recent, they're within that 10 years of menopause, they're normal weight, normal blood pressure, physically active, have a low ASCVD risk score, and their breast cancer risk is average or low. What does that mean? Low risk for breast cancer? I'm saying it's a 5-year risk under 3%, or it's in that under 15% lifetime risk. Intermediate risk, and again, they don't define it, but I'm going to define it here for you as a 5-year risk greater than 3%. I'm going to tell you that Catherine's in here, right? So she has diabetes and hypertension and high cholesterol. Her 10-year ASCVD risk score is 9%, and she's at an elevated risk for breast cancer. So I would tell you that she falls in this bucket where really shared decision-making comes in, right? So again, 23% lifetime risk of 23%. Her ASCVD risk score is 9.8%. She falls in this bucket. So how do I talk to her then, right? So I'm telling you, she's terribly symptomatic with hot flashes. She's also a candidate for chemo prevention. I'm certainly going to be talking to her about lifestyle. I'm certainly going to be getting annual MRI on her. What do I do with hormones? Do I immediately go to non-hormonal options? I would tell you I wouldn't. You might. But this is how I talk to her about it based on the data. Breast cancer, again, biggest risk of having breast cancer is being female and having breasts. What does the data from the WHI show us? If we look at population, if I have 100 women and I follow them from age 50 to 60, they're menopausal and no one goes on hormones, there will be 3 cases of breast cancer. If I take another 100 women and they go from 50 to 60 and I put them all on hormone therapy, and really if I put them on Prempro, right, conjugated equine estrogen with medroxyprogesterone acetate, most of us are not using that standard formulation, particularly orally right now. But if we were, I say it's worst case scenario, there would be 4 cases of breast cancer. So it's a 25% increase in breast cancer risk, but it's 1 extra case of breast cancer in 1,000 patient years. It's measurable, it's real. We have to talk about it. We can't pretend it doesn't exist. But how does that increase? How do I talk about it with this patient? And I say, if we really talk about a 20% increase, what your baseline risk is that 23%, right? If I give you 10 years of hormone therapy or more than 5, I'm going to increase it from 23% to 27%. You have to hear that with the patient, right? So it's increased. Now I want you to think about that if it's a patient who has a 9% lifetime risk and we increase it 20%. It goes from 9 to 11. It's still low. It's not 0, right? But it's not hair on fire, right? Like this patient is high risk. And depending on how symptomatic she is, if you educate her about this and she says, look, I need to manage my hot flashes right now. I'm miserable. I will talk to you about chemo prevention in the future, but like right now I'm miserable. I think you can make a case for low dose, and I would do transdermal hormones. I use transdermal most of the time. And this just came out last week as well. And this is again, and I just added this, and it's obviously a busy slide, but the point being, the 50 to 59-year-old category in both the E plus P and the E only arm had lower overall mortality. And if you look at breast cancer, even in this 20-year follow-up, the data is still the same. There's a reduction of breast cancer in the E only arm. There's a slight increase of about 20% in the E plus P arm. And again, the data just continues to play out. And I will go quickly through the rest. All right, so how do I do risk assessment? Family history screener to try to find those individuals who meet criteria for genetic testing. I educate patients about their risk after I do the modeling. I talk about prevention strategies with lifestyle, and then those people that meet guidelines for enhanced screening and chemo prevention, I'm talking to them about that. And what else do we know? You heard about SNPs before. I was so excited to see that. So this is really the new thing, right? So we know all about these genes that confer increased risk. But what we've now identified is those single base pair mutations, these SNPs that you heard talk about. There's about 300 of them. When taken collectively together, they confer increased risk for breast cancer. And we're just now starting to think about how we incorporate SNP testing into our risk assessment for patients. What we know is that abnormal SNPs are much more common. They confer much less risk than people who carry mutations, significant genes. But again, how we incorporate this into our risk assessment is really coming. And what else is coming? I mean, I think this is really an exciting time in medicine, although there's so many barriers to how we have equitable healthcare and how we're going to incorporate this because of cost. I mean, there's lots of problems, but the science is really incredibly cool right now in terms of how we're using AI to improve breast cancer screening, right? So using AI to do second reads on mammograms to actually improve catching early cancer tumors to make it more efficient. And then now we're talking about breast composition. So it's not just breast density, but this is breast composition. So parenchymal complexity. And so you can see that there's people who aren't dense but have high complexity. There's people who are very dense who have low complexity. And this is really now another data point in addition to the SNPs on how we're going to bring this into our whole risk assessment model. So where I think the future is still we should be doing risk assessment. We still need to find those mutation carriers. I think we're going to have much improved risk assessment models. One of the big pushbacks about using the Tyrer-Cuzick is that it really isn't the data comes from really European white individuals. It isn't very ethnically and racially diverse. So there's a lot of concern about application of the Tyrer-Cuzick to other ethnic and races, but it's all we have right now. We're going to be using SNPs. There's really some interesting science in using cell-free DNA screening and biomarkers and proteomics, which I didn't go into, and then the radiomics and AI. So taking all of that together, what I believe in the next 10 years is we really will have a way to give a woman really what we think a pretty accurate individual risk assessment is, and we can start to move to having screening guidelines based on risk, not just based on age, because we're really not doing it right. And then we'll have a much better approach to really identify those at very high risk so we can do prevention strategies. And I think the future is bright. And so as Camille said, so education is actually my passion. And so I really do this discussion group every Monday night. It's free. It's 8 p.m. Eastern Standard Time, 8 to 9 p.m. No obligations, totally free. You just have to go in and register so we get your email. And then every Thursday, you'll get an email with the topic for the week. And then at 6 a.m. on Monday, you'll get another email with the topic for the week. If you want to jump on and join, please do. If you don't. You can come once a year. You can come once a month. You can do anything you want. It's free. And the other thing, I would really love to invite you all to attend the Menopause Society meeting in Chicago if you can. In my opinion, it's the best meeting of the year. And thank you. I'm happy to take questions. And I almost made it. And thank you. And I don't know how to see the chat. So
yeah, I'm monitoring the chat. Repeat any questions for the virtual audience.
On the gadolinium? Yeah, so actually I don't think there's a lot of talk and chatter out there. I don't actually think there's enough data to raise concerns. Now, with that said, patients are concerned, right? And it's always about working with your patients. I would tell you that from my standpoint, I think there's patients we can probably get to every other year with breast MRI, right? The breast MRIs are so sensitive that, again, I think for just preventing that interval cancer detection, even every other year, this is again, right? Not evidence-based medicine. I have no guidelines to tell you to do it every other year, but I really work with patients if they're really worried about the gadolinium, or if they got that $4,000 bill and they just can't afford doing it, is really moving to the abbreviated and really doing every other year. But I hear that all the time from patients.
Thank you so much, Dr. Larkin. I do have a question I wanted to ask. So for Catherine, that last case that you presented, would you have picked Duave? I know you said transdermal is your go-to. And how would you differentiate the different types of progestins and progestogens in the market, since we have newer formulations now?
So I predict, Camille, you could answer that question very well and better than me. So Duave, how many of you know what Duave is? So Duave is a really fascinating medication, and it was off the market for a couple years, and it's been back on now for about 9 months. They had to pull it. It's a Pfizer drug. Had to pull it because of a packaging issue, not because of anything else. And I didn't realize that when you go back to the FDA, you have to actually go back with your new packaging too, not just the product. So it took a while for them to get it back on the market. But Duave is conjugated equine estrogens, which was obviously the estrogens used in the Women's Health Initiative data. And remember, in the conjugated equine estrogen arm, there was a breast cancer reduction, right? So from the WHI, I think we all really believe that medroxyprogesterone acetate, and the data supports that, is part of the breast cancer issue, right? It's not the Premarin. So there's a lot of chatter, and those of us that discuss this that think that the conjugated equine estrogens actually acts like a SERM, and that may be the way that there is breast cancer, why the data continues to show a reduced incidence of breast cancer. But so Duave is a combination of the conjugated equine estrogens with basodoxifene, which is a medication very similar to tamoxifen, but it is used for endometrial protection. It's really effective. So in patients who have bleeding, spotting, they're frustrated, right? There is no better option, in my opinion, for bleeding control with patients than Duave. But the other thing about Duave is, and again, you can't say this to patients, there's no data for me to actually say it decreases breast cancer incidence. In animal models, there is data that it decreases breast cancer incidence, and there's surrogate markers about decreasing breast density as a surrogate marker for breast cancer. And there are trials that are ongoing right now, but it is a good option. And again, I don't know, I would love your opinion. I mean, you're very experienced in this too, that it is something that I would talk with her about. Absolutely. I would say, so Duave is a good option. For me, the other thing in practice is that often you need a really small dose of estrogen to actually get someone's symptoms under control. So using a 0.025 patch, which is really less than half of the dose, the estrogenic effect that was used in the WHI, right, often is great for patients. And so you don't need a lot of estrogen to get their symptoms under control. So again, I think using low dose patch, Duave would be a good option. I think both of those are great. And to just end the data about the progestins, I think there is data to suggest that natural micronized progesterone, so the bioidentical, and again, patients come in, they want bioidentical. You can really talk to them about progesterone as the bioidentical, that there's data, again, that there is no increased incidence of breast cancer with that. And so again, I think the regimen that we're using is different than what was in the WHI. And I think most of us feel like, again, that 25% increase is probably less than what we're doing now. So that number I said of 3 cases to 4, I think is less than that. But I don't minimize it with patients, right? Because you never want a patient to come back. And I do say, like, we can start you on hormones or not start you on hormones. You still have breast cancer risk, like it's there. And so you never can say that the hormones are what drove the breast cancer if they come in with breast cancer, but you want to make sure that they're fully informed.
Thank you for that very thorough explanation. We have time for 1 to 2 more questions. So people in the Zoom room, if you have any questions, please feel free to write in the chat. And Dr. Degree has one.
So you keep mentioning preventive chemotherapy for people at high risk. What is
Oh,
that?
sorry. So I'm sorry. Yes. So in premenopausal women, we can use tamoxifen. And actually, there's lots of concern about tamoxifen causing endometrial hyperplasia and endometrial cancer and being associated with clotting risk. But actually, the data in premenopausal women is really good. In fact, it's very well tolerated, and we're now using lower dose. And there's some data in using, and I don't know what your dose you're using, but you can get away instead of using 20 milligrams every day, which is what I'm on. You can do 10 milligrams every other day, and women tolerate it incredibly well. When I talk to patients about that, so that's premenopausal, we'll start there. When I talk to patients about it who say, oh my God, I'm never taking that, I really push them to say, like, look, if you get 1 year or 2 years in, if you can try it for 90 days, like, I bet you're not going to notice it. I mean, if you can really tell them, like, look, your calculated risk is 24%. The data is if you get 5 years in, it goes to 12%. Like, that's really substantial. Like, we should try this. Like, this is the best thing that we have. So tamoxifen for premenopausal women. For postmenopausal women, again, tamoxifen is less commonly used. We typically use an aromatase inhibitor, so Arimidex, or raloxifene is often what I use a lot, right? So you're kind of getting both osteoporosis prevention and treatment with the raloxifene, and it's very well tolerated. And I don't know if you have any other pearls for people or you do it differently.
I commonly also counsel patients on those options. So depending on if they're symptomatic and have vasomotor symptoms
Right.
or arthralgias, and you pick one category versus the other.
And I think that's the other thing about the chemo prevention or using the medication, right? There's no set time that you have to do it, right? So you do want to base it based on symptoms. Like, the best time is probably not in that 52, it isn't in the 52-year-old that has severe vasomotor symptoms. I mean, you really, if you can get them through that for a couple of years, they're doing a lot of better, right? The majority of women will have resolution of their vasomotor symptoms in 7 years, not everybody. But again, if you can wait, they often do much better. But again, shared decision-making all along the way.
I think we have one question in the back,
Sorry.
and then we'll come to you.
So realizing there's no such thing as immortality, has anybody looked at what high-risk women who succeed in preventing breast cancer end up getting instead and dying of? For example, a more difficult, unpopular gallbladder and bile duct, all those cancers
Yeah.
that are like treatable, or do they have higher incidence of some sort of cardiovascular?
So I can't answer that at all. Certainly, right, if we identify mutation carriers, that's a different thing. But right, breast cancer survivors do have a higher incidence of second malignancies for sure. So I don't really have the data of that. But you're 100% right. Like, I say all the time to myself, because my patients have all aged with me, right? So I have a lot of 90-year-old patients right now, and it's not great being 90 all the time. Like, I often say, I hope I just wake up dead, because I survived breast cancer, but I really want to wake up dead. And it's hard because with longevity and longer life expectancies brings other problems, right? Cognitive decline and dementia and frailty and so I don't have the answers.
Thank you so much. So that's the conclusion of our questions. And then we're going to invite Dr. Silver to the virtual platform. Dr. Silver, if you don't mind turning your video on.